Good day, everyone. My name is Luisa Rodriguez, and my field of study is nursing. I chose to publish for Scrubs magazine, whose focus is to provide a lifestyle-based perspective of nursing and its daily occurrences. Scrubs magazine mainly appeals to an audience of female, established, and prospective nurses, as well as casual readers. In order to build and maintain a personable reader-writer connection, which is notorious in Scrubs articles, I imitated the publication's informal diction, friendly tone, easy-to-follow instructional structure, simple but meaningful statistics, and the second-person point of view. I chose not to imitate the use of anecdotes and photos because I felt that the article spoke for itself without the need of personal experience, and I felt that photos would not only make my paper seem a bit cluttered, but also take away from the information within my text. For my initial topic, I decided to research dissociative identity disorder. Previously known as multiple personality disorder, DID is a mental disorder that is characterized by the presence of multiple personalities within one single body. Due to its very distinct symptoms, causes, and varying presentation within patients, it is not only commonly misdiagnosed with other mental illnesses such as schizophrenia and hysteria, but it is also a very controversial illness in general. As I began my research, I first wanted to cover the premises of DID and its surrounding factors. For starters, DID is caused by childhood trauma, as a clinical study published in a Scandinavian psychiatric journal further validates. Then I moved on to the obvious symptoms and characteristics of DID, being the altered personalities. These personalities have their very own set of traits and characteristics that often vary and are very different from that of the host or the original personality. In fact, as I was doing my research, I even came across a book titled The Strange Case of Dr. Jekyll and Mr. Hyde, in which the main character, Dr. Jekyll, embodies the duality of DID. Then I moved on to the main trigger of dissociation or personality switches, being skepticism. DID patients often feel judged and rejected due to their illness, and skepticism tends to put them under distress and eventually cause dissociation. Finally, I moved on to the possible treatments for DID, as there is no cure for the illness. There are multiple treatment options such as trauma counseling, therapy, and hypnosis, all of which are completely subjective to each patient and vary on a case-to-case basis. Upon concluding my initial research, I decided to focus the bulk of my article on the following question. As a nurse, what are the proper ways of treating and communicating with DID patients? As I continued my research, I started noticing an unfortunate trend. Although there is a lot of information regarding DID and its biology already out there, there seems to be a major gap in information as far as the patient care perspectives. As people who deal with the body's complexity and unpredictability on a daily basis, I feel it is very important for medical professionals to freshen up on their bedside manner, as well as their ability to handle the unexpected situations that may arise from patients with dissociative identity disorder. In my article titled, Don't Know How to Address or Treat Your Patient with DID, Here is How, I began by covering the basic information on DID. However, upon doing so, I immediately shifted the focus of my paper to a patient care perspective of the illness, not the biology behind it. I then covered the controversy surrounding DID, being its cause. Once again, DID is caused by trauma, not a chemical imbalance, which often creates room for clinician skepticism and even unintentional dismissive jargon. I've attached a graphic here that lists some of the myths and facts of DID that can be very helpful for other medical professionals. Of course, I also wanted to establish the overarching theme of the bulk of my paper, being the importance of keeping emotions under control. I realize it isn't an easy situation, but appearing nervous or even afraid won't help the situation anymore. In my paper, I also wanted to cover the process of a regular doctor's visit with a DID patient. For starters, remember that first impressions are important. Simply greet your patient, introduce yourself, and verbally state what type of procedure and questions will be taking place during their visit. Remember to control your facial expressions upon seeing their diagnosis, as expressions of fear, concern, and/or disgust can put your patient under instant distress. When addressing the diagnosis, remember that there is a right and a wrong way to approach the situation. A good rule of thumb is to remember that you're always asking your patient, you're never telling them. If your patient ever seems reluctant to answer any further questions, they are well within the right to stop, and you must not push. If dissociation were to ever take place during a task, remember to stay calm and simply use your words and explain, but do not address the switch. If dissociation happens during a procedure, you must stop what you're doing unless stopping jeopardizes the health of your patient. You want to be very verbal and clear once again before any further contact, especially if the procedure requires any sort of physical contact. In the future, I would not only like to see medical professionals attempt to remain more up to date with other specialties, but also I would like to see an annual mental illness training program be implemented for medical professionals in order to provide them with the information they need to offer the best possible care to each and every one of their patients, regardless of their medical background. With that, I'd like to leave you with this last thought. Remember that living with DID and any other mental illness is your patient's normal. Don't ever make them feel wrong for adapting. Instead, try to adapt your practice to their illness so that you can offer them the best possible care.